Welcome to this new session of Transplant International Podcast.
Hello, everyone, and welcome back to the Transplant International Podcast, where we explore the scientific advances and clinical innovations shaping the future of transplantation. I'm Nina Pilat, Deputy Editor-in-Chief of Transplant International, and your host for today's May episode. Today, I'm very happy to be joined again by my Editorial Fellow Delphine, who will help guide us through the papers we selected for this month.
Great to be here, Nina. My name is Delphine Kervella. I am nephrologist and transplant immunologist in Barcelona and also a TI editorial fellow. We've picked 3 papers for this episode, 1 basic science paper in lung transplantation and 2 clinical papers focusing on compatibility and desensitization issues in kidney transplantation.
I'm already looking forward to dive in. For any new listeners, our goal is not to replace the papers, but to give you a concise, critical overview that makes you want to dive into the full articles, look at the figures, and think about how these findings intersect with your own practice or research. Before we begin, a brief reminder, the views expressed in this podcast, they are our own, and they do not necessarily reflect those of Transplant International or ESOT. So we'll start with our basic science highlight, blood vessels as primary site of rejection in murine lung transplantation by KZ colleagues from Leuven and collaborators. Lung transplantation has long been framed as an airway-centered disease when it comes to chronic dysfunction. We all think bronchiolitis obliterans obliterated small airways, RAS versus BOS, but this murine study asks a pretty fundamental question. What if rejection in the lung is actually vessel-centered from the start?
Exactly. The group used a major mismatch orthotopic left lung transplant model in mice with daily immunosuppression and followed isografts and allografts at days 1, 7, and 35. They combined several powerful tools to analyze the outcomes. First, longitudinal in vivo micro-CT to follow lung volume and density. Also, high-resolution ex vivo micro-CT with 3D segmentation of airways, arteries, and veins. They also used multicolor flow cytometry on whole grafts to track leukocytes and endothelial cells and their activation. And finally, they used geomics, spatial proteomics, to map where immune and structural proteins are expressed, like in arteries, veins, airways, and parenchyma. So this is really a spatiotemporal dissection of rejection.
And what they see is quite striking. By day 7, what they interpret as the acute rejection phase of their model, you have a peak of leukocyte infiltration, the loss of endothelial cells in the allograft, also endothelial activation with increased WECAM1 expression, and increased MHC1 and 2 on endothelial cells. So the endothelium is not just a passive bystander, it's activated, presenting antigen, and seemingly orchestrating the immune response.
Histologically, you see dense cuff-like perivascular infiltrates at day 7, extending to the pleura. And over time, by day 35, those cuffs evolve into plasma cell-rich infiltrates, which with progressive perivascular fibrosis and then bronchovascular fibrosis. Airways, interestingly, remain largely preserved early and only show peribronchial fibrosis later, almost as a secondary event. Spatial proteomics reinforces this vascular focus. Around arteries in allografts, you see enrichment of CD45, CD4, CD44, CD19, and markers of both innate and adaptive immunity. There is increased Ki67 around arteries and in parenchyma, and there is a relative decline in regulatory markers like CD39, CD163, PDL1, FOXP3 in veins and parenchyma. So the hotspot of immune activity is clearly vascular and especially arterial.
And then the ex vivo micro-CT brings it into 3D. At day 35 in the allografts, the arteries and veins, they are narrowed, pruned and embedded in dense fibrotic tissue, while the airway architecture is relatively preserved, with obstruction appearing only late and secondarily. This is a nice bridge to the clinical CLAD where we see pulmonary arteriopathy and venopathy described in both BOS and RAS, but we probably still underappreciate their contribution.
So the authors framed day 7 as acute rejection and day 35 as chronic rejection, at least in this model. And the central message is that endothelial cells are early targets and active players. There's persistent alloantigen that drives ongoing endothelial activation, which then leads to maladaptive repair and perivascular fibrosis spreading into parenchyma, pleura, and airways. So the authors argue for a vessel-centered concept of lung rejection much closer to the paradigms we already have in heart and kidney transplantation.
Right. And the question is, why should clinicians and translational researchers care? I would highlight 3 points. This article challenges the airway-centric dogma and invites us to look much earlier at the vasculature in lung transplant patients, both histologically and also with imaging. Also, it suggests that the endothelial preserving or endothelium-targeted therapies, they might be a rational avenue to prevent chronic rejection. And it supports the idea that vascular imaging, perfusion, microvascular remodeling, it might serve as an early biomarker for evolving rejection. So importantly, the authors highlight that the model developed in this manuscript is a model of chronic rejection and not of CLAD, as the definition of CLAD is clinical, functional, and CLAD is multifactorial process in which rejection plays an important role. If you're interested in CLAD mechanisms in designing new endpoints or thinking about imaging-based early detection, I think this is a paper to read in detail, especially the figures with the spatial proteomics and the 3D reconstructions.
So we now move to kidney transplantation and another compatibility theme, the ABO-incompatible living donor transplantation. And the paper we're going to highlight now is ABO-incompatible kidney transplantation, impact of apheresis on graft and patient survival in recipients with low isoagglutinin titer by Manja and colleagues from several French centers. The clinical dilemma here is very specific. If a recipient has low baseline anti-A or B titers, say IgG lower or equal to 1/8, do we really need to subject them to pre-transplant apheresis with all its logistical and infectious complications?
They conducted a multicenter retrospective study in 78 ABO-incompatible living donor kidney transplant kidney recipients from 2012 to 2022, all with a baseline IgG, ND-A or B titers smaller than 1/8. And 41 patients, they received pre-transplant apheresis, mostly plasma exchange, sometimes immunoabsorption, and 37 patients who did not. And almost all patients received rituximab, and they were otherwise managed with center-specific immunosuppressive protocols. The primary composite outcome was event-free survival, that is, free from graft loss or death. So they also carefully documented ABMR, T-cell-mediated rejection, delayed graft function, isoagglutinin rebound, and also infections.
Across the whole cohort, overall outcomes were very good. Patient survival was about 99.5% at 1 year, 97% at 3 years, and 95.5% at 5 years. And about graft survival, 94% at 1 year, 90% at 3 years, and 86% at 5 years. So even in ABO-incompatible recipients with modern protocols and low titers, this is quite reassuring. But then when you split by apheresis versus no apheresis, some differences emerge. First, rejection episodes were more frequent without apheresis, about 40% versus 15%. And there was a trend toward more early ABMR and delayed graft function, often associated with thrombotic microangiopathy in the no apheresis group. And overall, event-free survival, considering death or graft loss at 3 years, was 90% with apheresis versus 79% without. And at 5 years, it was 86% with apheresis versus 68% without apheresis.
So in the multivariable Cox analysis, the pre-transplant apheresis was independently associated with a better event-free survival with a hazard ratio about 0.301, while the ABMR within the first month was strongly associated with worse outcomes. Perhaps equally important, they did not find a major increase in overall infections in the apheresis group. They were slightly more fungal, parasitic infections in the non-apheresis group, and a trend towards more CMV in the apheresis group. But there was no dramatic safety signal either way, which is a good thing.
And an interesting nuance is induction. Patients receiving thymoglobulin plus apheresis had the best event-free survival in the cohort. So the combination of antibody removal and depleting induction seems particularly protective, of course at the price of more intense immunosuppression. The authors also discuss an important methodological issue. Isoagglutinin titers are notoriously variable between laboratories and techniques. So a titer that looks low in one center may not be strictly comparable elsewhere. And they also report a striking anecdote. One patient with IgM titer of 1 to 32 who did not undergo the apheresis developed cortical necrosis and primary non-function, suggesting that even low IgG may not tell the whole story.
And so what's the take-home message now? In this low-titer ABO-incompatible setting, outcomes are overall excellent. But omitting apheresis was associated with more rejection, more delayed graft function, and lower event-free survival. So without a clear reduction in infectious complications. The authors conclude quite explicitly that apheresis should still be systematically considered before an ABO-incompatible kidney transplantation, even in the patients with low baseline titers, at least until we have better, more specific assay to truly define the low risk. And for transplant nephrologists, immunologists, and the apheresis teams, this is an important contribution to an active debate. Can we safely simplify the ABO-I protocols in some patients or not?
So we move to our final paper that stays with kidney transplantation, but move from ABO to HLA compatibility and desensitization. And this is a letter to the editor from Mexico entitled Human Leukocyte Antigen Incompatible Living Donor Kidney Transplantation After Desensitization, Experience from a Major Transplant Center in Mexico by Reynoso de la Torre and colleagues. It's a single-center retrospective cohort of 65 highly sensitized living donor recipients treated between 2018 and 2022 with at least 12 months of follow-up.
And the clinical problem here is very familiar. In highly sensitized patients, often with multiple donor-specific antibodies and positive cross-matches, access to the compatible donor is limited, especially in regions with fewer kidney exchange programs and DSA biobanks. So this center expanded HLA-incompatible living donor transplantation using individualized desensitization. So 20 of their patients received IVIG alone, and 45 patients received a triple regimen with plasmapheresis, IVIG, and rituximab. And all of them had flow cytometric and CDC cross-matches and Luminex DSA testing prior to desensitization. Most of the patients received ATG induction and the standard triple maintenance immunosuppression.
Despite being high risk, the results are encouraging. They show that acute rejection occurred in about 20% of patients, all antibody-mediated, with no significant difference between IVIG only and triple regimen desensitization. 12-month eGFR was good and comparable between groups, and graft survival at 1 year was high in both groups. Regarding infectious complications, they show mainly urinary tract infections. Viral infections such as CMV and BK were relatively infrequent, and overall mortality was 6.2%, all infection-related, comparable to other desensitization cohorts.
And a couple of subtleties that are worth mentioning, it's that the patients selected for triple desensitization regimen, they had on average higher class 2 DSA MFIs. So it wasn't a randomized comparison. So it really reflects risk-based tailoring. And pre-transplant class 2 DSA did not clearly predict rejection, graft loss, or lower EGFR in this cohort, which is interesting given the broader literature. Also, around half of the patients, they had a positive flow cross-match. A small minority had positive CDC cross-matches and still proceeded after desensitization. Among those, one developed AMR at 12 months, but preserved function. Another one died from infection with a functioning graft.
They also looked at histocompatibility. Fewer shared HLA haplotypes were the only factor independently associated with increased rejection risk, reinforcing the idea that better matching still matters, even when we desensitize. And they underline an important message. In the Latin American context, where paired exchange and large DSA-based allocation systems are less available, individualized desensitization can safely expand living donor transplantation in highly sensitized patients with acceptable early outcomes.
So, summing up, for centers facing similar constraints, this letter is a valuable proof of concept. It shows that with structured risk assessment, so DSA, cross-match, prior sensitizing events, flexible use of IVIG, plasmapheresis, rituximab, and also close infectious monitoring, you can achieve outcomes in line with international experience instead of leaving highly sensitized patients on dialysis indefinitely. It resonates with recent European consensus efforts of managing sensitized candidates, also emphasizing stratified risk and tailored protocols rather than a single desensitization recipe.
So to briefly recap our May selection, a murine lung transplant study reframing chronic rejection as a vessel-centered process driven by endothelial activation and perivascular fibrosis. Then a multicenter French study arguing that even with low ABO titers, apheresis still seems to protect against early ABMR and improve event-free survival in ABO-incompatible kidney transplantation. And finally, a Mexican single-center experience showing that individualized desensitization for HLA-incompatible living donors can yield good early outcomes in highly sensitized recipients, even in resource-constrained settings.
Thank you. And all three papers in different ways push us to rethink our assumptions about compatibility and vascular injury. For example, how early devasculature is involved in lung rejection, how far we can safely simplify the ABO-I kidney protocols, and how to responsibly expand access to transplantation for sensitized patients when the perfect compatibility isn't available. Here, we've only scratched the surface of data and methods. To really appreciate these studies, we encourage you to read the full articles in the May issue of Transplant International with all the figures, supplementary analysis, detailed methods, and it will be well worth your time.
The May issue, including these papers, is available open access on the Transplant International website. If you enjoy this podcast, you can subscribe through your usual podcast platforms so you don't miss future issues.
Also, I briefly want to highlight the extraordinary cover article of this month's Transplant International issue. The paper is titled, "What is possible for patients after lung transplantation?" The highest reported altitude achieved by a lung transplant recipient without supplemental oxygen. He was climbing Mount Aconcagua. It truly redefines our understanding of what is medically and humanely possible after a transplant. It documents a lung transplant recipient conquering the highest peak in Americas completely without supplemental oxygen. Plus, we have an editorial reflecting on what these milestone achievements mean for the post-transplant quality of life, also on the boundaries of rehabilitation. As this story can't be told in a few minutes, we are dedicating an entire special episode where we have the pleasure to interview Dr. Jakob Mühlbacher, transplant surgeon, first author of the study, and expedition doctor. For now, you can read both the article and the editorial on our website.
And we'll be back with more highlights from the upcoming issue next month.
Thank you so much, Delphine. This has been the May episode of Transplant International Podcast. Don't forget to subscribe, and we'll be back soon with more conversations and insights from across the field.